Hello, my dear students. This lecture is divided into two parts. In the first part, we will talk about drugs used to treat respiratory system disorders, and in the second part, we will talk about local anesthetics. This is a brief introduction about respiratory system. The respiratory system is responsible for supplying the body with oxygen, also eliminating carbon dioxide from the body, and maintaining the body acid-base balance. By parasympathetic stimulation, like by acetylcholine neurotransmitter, this leads to bronchoconstriction. On using sympathomimetic drugs or anticholinergic drugs, this leads to decrease the volume of mucus and increasing its viscosity that facilitate its expulsion. Also, at the same time, sympathomimetics or antimuscarinics will lead to relaxation of bronchial smooth muscle. Physiological substances like histamine and prostaglandin. Histamine is a physiological substance produced in the body in response to allergen, leads to bronchoconstriction, while prostaglandin E2 will lead to bronchodilator. Now we will talk about some respiratory system disorders, like the first respiratory system disorder is the bronchial asthma. It is an inflammatory disease in which the airways are blocked. The second respiratory system disorder is called chronic obstructive pulmonary disease, or COPD, which includes chronic bronchitis. Both bronchial asthma and COPD could be treated by bronchodilators, and we will study them later on. The third respiratory system disorder is the rhinitis, which is inflammation of mucous membranes of the nasal cavity, and it is characterized by dilatation of the nasal blood vessels leading to nasal congestion. The third or the fourth respiratory system disorder is coughing. There are two types of coughing, which is productive cough and non-productive cough. Productive cough is characterized by presence of mucus in it, and it is accompanied by expectoration or expulsion of sputum or mucus. The treatment strategy will be the use of expectorants that can facilitate the expulsion of the mucus or the secretions. The second strategy is the mucolytics that decrease the viscosity of the mucus and facilitate its expulsion. The second type of cough is a non-productive cough, which is a reflex mediated by centers in the brain called medulla oblongata, and the treatment strategy will be the use of antitussive drugs that reduce cough by acting on the control centers in the medulla oblongata. Now we will study drugs used to treat asthma and chronic obstructive pulmonary disease. There are two main types of drugs that used to treat asthma and COPD, which are bronchodilators drugs and anti-inflammatory drugs. And now we will study the first type of drugs, which are bronchodilators. Bronchodilators are further classified into three main types of drugs. The first is B₂-Selective adrenergic agonists that cause stimulation of beta-2 receptors leading to bronchodilation. The second type is the muscarinic antagonists. They are drugs which block the muscarinic receptors and preventing the action of acetylcholine and prevent acetylcholine from binding to these muscarinic receptors, leading to relaxation of smooth muscles in the bronchi and leading to bronchodilation. The third class or the third type is the xanthine bronchodilators. All these three types of drugs are bronchodilators. Let us start by beta-2-selective adrenergic agonists. As we said before, stimulation of beta-2 adrenergic receptors lead to relaxation of bronchial smooth muscles and causes bronchodilation. And here we will study the two examples on beta-2-selective adrenergic agonists, like norepinephrine and salbutamol. Norepinephrine contains catechol ring. This ring is called catechol ring, the benzene ring with two OHs called catechol ring, and incorporating also the phenylethylamine. Phenylethylamine. This is the norepinephrine. The second drug is the salbutamol. Salbutamol does not incorporate the catechol ring. This isn't a catechol ring, but also it contains the phenylethylamine. But there is a lipophilic chain on it, small lipophilic chain called tertiary butyl group on nitrogen. This is the salbutamol. Both norepinephrine and salbutamol are short-acting beta-2 agonists and acts directly on the receptor active site, which are the beta-2 adrenergic receptors. Both norepinephrine and salbutamol used to treat acute asthma, and they are not used in chronic asthma. They are used only in acute asthma as they are short-acting agonists. We have finished the short-acting beta-2 selective adrenergic agonist, and we studied the norepinephrine and the salbutamol as short-acting beta-2 selective adrenergic agonists that used in acute asthma. And now we will study the long-acting beta-2 agonists like salmeterol. Salmeterol is a long-acting beta-2 agonist, and it is used in treatment of chronic attacks of asthma, not in acute asthma. For acute asthma, we use the short-acting beta-2 agonists, while in chronic asthma, we use the long-acting beta-2 agonists. Advantages of beta-2 agonists: has less frequent administration, has greater convenience to the patients, and can control symptoms of asthma more effectively. This is the structure of salmeterol. It has long lipophilic chain, so it is highly lipophilic drug and can penetrate the outer phospholipid layers easily and can act as a depot. So salmeterol is has long duration of action, and it is highly lipophilic drug and used in treatment of chronic attacks of asthma. We're still talking about bronchodilators. We took the first class, which is the beta-2 selective adrenergic agonist. We studied the short-acting beta-2 agonist like norepinephrine and salbutamol. Then we studied the long-acting beta-2 agonists like salmeterol. And now we will study the second class of bronchodilators, which is muscarinic receptor antagonists like ipratropium bromide or ipratropium. Ipratropium is a muscarinic antagonist that block the muscarinic receptors and prevent acetylcholine from binding to these muscarinic receptors. Ipratropium contains quaternary amine. I want to note that histamine-induced bronchoconstriction. Histamine is a natural physiological substance that is produced in the body in response to allergen. When histamine is produced, leads to bronchoconstriction as it stimulates a reflex called vagal reflex. This vagal reflex leads to bronchoconstriction. So we can use ipratropium bromide in order to reduce this vagal reflex, which is the vagal bronchoconstriction. So ipratropium bromide is a muscarinic blocker that contains quaternary nitrogen. It is a derivative of atropine, and it is used in treatment of chronic asthma in patients who cannot be managed with beta-2 agonists. It has atropine-like side effects. The third class of bronchodilators are xanthine bronchodilators that incorporate purine ring and called purine derivatives. The widely used xanthines are thiophelline and its salts, aminophelline, which incorporates ethylene diamine salts, and oxytriphelline, which incorporates choline salts. Both aminophelline and oxytriphelines are thiophylines, which are purine derivatives. This is called purine ring. This ring is called purine rings. Both aminophelline and oxytriphelines are phosphodiesterase inhibitors. Due to dose-related toxicity, serum level monitoring is recommended for both aminophylline and oxytrifylline. Now we have finished the first class for treatment of asthma and chronic obstructive pulmonary disease, which is the bronchodilators, and we have studied in the bronchodilators three main classes, which are the beta-2 agonists and the muscarinic antagonists and xanthine bronchodilators. Now we will study the anti-inflammatory drugs for treatment of asthma and chronic obstructive pulmonary disease. We will take three main classes in this anti-inflammatory drugs, which are mast cell stabilizers and leukotriene antagonists, and the third anti-inflammatory drugs are corticosteroids. Now we will study the mast cell stabilizers. Mast cell stabilizers, they are drugs that stabilize mast cells. Mast cells are cells present in the body. These cells can release histamines, leukotrienes, and other mediators in response to allergens. Mast cell stabilizers like cromolyn sodium. This structure is called cromolyn sodium. It is a prophylactic drug. It has no value in acute asthma. It is not used in acute asthma. It contains chromone ring system. These four ring systems called chromone ring system. This cromolyn sodium is beneficial. Effects appear after several weeks. It stabilizes the membrane of the mast cells and prevents mast cells from releasing histamines, leukotrienes, and other mediators that lead to inflammation to the airways. Now we have finished the first class of anti-inflammatory drugs, which are mast cell stabilizers, and now we will study the leukotriene antagonists. What are leukotrienes? Leukotrienes are a group of arachidonic acid metabolites formed by the 5-lipoxygenase pathway. As we know, lipids by phospholipase enzyme leads to formation of fatty acids, which are arachidonic acids. Arachidonic acids has two pathways, which are prostaglandins formations and leukotriene formation by 5-lipoxygenase enzyme. Leukotrienes and prostaglandins are mediators that mediate inflammatory responses. So we have to block the effect of leukotrienes by using leukotrienes blockers or leukotrienes antagonists in order to stop inflammation or to stop inflammatory responses. We will take an example from leukotriene antagonist, which is the zafirleucost. Zafirleucost is a prototype of leukotriene inhibitor. It's similar to the structure of peptidoleukotriene, and it is a competitive blocker for leukotrienes receptors. This is the structure of zafirleucost. It is a bulky structure, and it is a prototype of a leukotriene blocker. We're still talking about anti-inflammatory drugs, and we have finished the mast cell stabilizers and the leukotriene antagonist. Now we will talk about corticosteroids. Corticosteroids like piclomethasone, budesonide, and fluticasone are anti-inflammatory drugs. And this is the structure of piclomethasone. It has the 4 fused ring, which is characteristic for corticosteroids. This is the piclomethasone. It is called piclo due to presence of chlorine atom. These corticosteroid drugs are used for prophylaxis of asthma. In patients using adrenergic agonists more than once daily. Now we have finished drugs used to treat bronchial asthma and chronic obstructive pulmonary disease, and now we will study drugs used to treat respiratory secretions and cough. We will talk about two classes, which are antitussives and expectorants and mucolytics. The first class, antitussives, we will take two examples on antitussives like benzonatate and dextromethorphan. This is the structure of benzonatate. It is a drug which is used locally to anesthetize the afferent nerves that initiate the cough reflex. It is used for non-productive cough. Also, dextromethorphan, it is from an opioids. It is used centrally to inhibit cough centers in the brain, to inhibit cough. So these two drugs, benzonatate and dextromethorphan, are antitussives. One of them, which is benzonatate, acts locally, and the dextromethorphan acts centrally. The second class of drugs for treatment of respiratory secretions are expectorants and mucolytics. What are the difference between expectorants and mucolytics? Expectorants are drugs that can promote ejection of mucus from lung, bronchi, or trachea by increasing water content of bronchial secretions and facilitating a mucus flow that can be removed easily through coughing. Expectorants has two types. Either they can act directly or indirectly. First, the indirect acting expectorants like emetics, such as epica, ammonium chloride, potassium iodide, sodium citrate, and ammonium citrate, while the directly acting drugs, which increase mucus secretion by increasing water excretion from the mucosal glands, like guaifenesin and bromohexin. Bromohexin can act as an expectorant and act as a mucolytic. These are two structures of the directly acting expectorants. The guaifenesin, its nomenclature is propan 1,2-diol. This is a propan 1,2-diol. On 3 position, this is carbon number 1, carbon number 2, and carbon number 3. On carbon number 3, there is 2-methoxyphenoxy. This is phenoxy, and on 2 position there is methoxy, propan-diol. So guaifenesin is 3,2-methoxyphenoxy propan 1,2-diol, while bromohexin is called bromo due to presence of 2-bromine, and there is a cyclohexyl group. Bromohexin, as we said, can act as a mucolytic and as an expectorant drug. Mucolytics are drugs that decrease the viscosity of the mucus, thus facilitating expulsion of the mucus from the airways, like acetyl, cysteine, and ambroxol. Ambroxol is N-demethylated active metabolite of bromohexin. Here, ambroxol is a structure similar to bromohexin, but ambroxol is N-demethylated form of bromohexin. So acetylcysteine and ambroxol are mucolytics. Acetylcysteine, its nomenclature is 2-acetamido-3-sulfonyl propanoic acid. It is propanoic acid 1, 2, 3. It is propanoic acid. On 2 position there is acetamido group, functional group. On 3 position there is a sulfonyl group. So acetylcysteine and ambroxol are mucolytics or mucolytic drugs. Now we will talk about drugs used to treat rhinitis. As I said in the beginning of the lecture, the cause of the rhinitis is the vasodilatation of the mucosal blood vessels. So we have to use sympathomimetic drugs in order to cause vasoconstriction of these mucosal blood vessels, which reduces the edema of the nasal mucosa. Since these sympathomimetic drugs can act either directly like phenylephrine or indirectly like methyltramine and ephedrine. These sympathomimetic drugs are of limited value. Why? Because they can cause rebound congestion on withdrawing. On stopping these sympathomimetic drugs, nasal congestion may return again to the patient. This is called rhinitis medicamentosa. Ephedrine nasal drops is the safest sympathomimetic preparation and can give relief for several hours. Please note that all these preparations, all these sympathomimetic drugs can cause hypertensive crisis if used during treatment with monoamine oxidase inhibitors. As you know, these MAO inhibitors or monoamine oxidase inhibitors inhibit the metabolism of sympathomimetics like adrenaline, noradrenaline by monoamine oxidase. So if we treat the patient with these sympathomimetic drugs, we should not give the patient monoamine oxidase inhibitors in order to avoid this hypertensive crisis. These are the structures of sympathomimetic drugs: methyltramine, ephedrine, and phenylephrine. As you see, Methyltryptamine is phenylethylamine, while ephedrine and phenylephrine are phenylethanolamine. Phenylethanolamine. The difference between ephedrine and phenylephrine, both are phenylethanolamine, but ephedrine contain methyl group at alpha carbon, while there is no methyl group here in phenylephrine. Also, phenylephrine has one OH on the phenyl ring, while ephedrine lacks any OH on the benzene or the phenyl ring. So, methyltryptamine is phenylethylamine, while ephedrine and phenylephrine are phenylethanolamine. Methyltryptamine is indirectly acting sympathomimetic drug. Also, ephedrine is indirect acting sympathomimetic drug, while phenylephrine is the direct acting sympathomimetic drugs. Please study well the collective structures in the slides. This make you easily memorize the drugs in the exam. Thank you.